Once in a while, each and every one of us surgeons may be faced with a scenario wherein we are going ahead with the phacoemusification and suddenly things go so wrong and we do need to convert to either an extracapsular cataract surgery or to a manual SICS. In this video, I'd like to share with you the exact technique of converting to a manual SICS when you're going ahead with phaco with a fragment still in the eye. We now move to understanding which was this patient that we took up for surgery. Now, this patient clinically appeared to have a 4 clock hour of zonular dialysis with a grade 3 nucleus sclerosis. The surgical plan was going ahead with putting in a capsule tension ring. If required, I would have also implanted a scleral fixated Ahmed segment or a capsule tension segment, and the nucleus emulsification performed using the direct chop technique. We now move to watching the surgery. Now, when we started the surgery and I re-evaluated the nucleus, there seemed to be almost a 5 clock hour of zonular dialysis. Now I'm fairly certain that at the end of nucleus emulsification, I am going to need to insert a scleral fixated Ahmed segment in order to fixate this capsular bag. We start with meticulously created incisions and a cohesive viscoelastic to flatten the anterior chamber prior to performing the Capsulorhexis. Remember that there are significant challenges when you do perform a Capsulorhexis in a subluxated cataract. Because of the lack of the equal forces pulling on the anterior capsule in all directions, as you proceed with the Capsulorhexis, especially in the area of the zonular dialysis. Therefore, you often need to resort to the use of an intraocular forceps to be able to complete the rhexis. It's also important to remember where is the center of the nucleus in a subluxated cataract and try and ensure that the Capsulorhexis that you create is centered onto the center of the nucleus. Next, we proceed to the insertion of the capsule tension ring. In order to aid the easy passage of the leading haptic of the CTR, I always inject a cohesive viscoelastic at the proposed point of entry between the capsular edge and the nucleus, thereby facilitating ease of entry of the leading eyelet of the capsule tension ring. A suitably sized capsular tension ring is taken, and once it is thoroughly washed, it is then introduced into the capsular bag with the technique that we will now demonstrate, that is a hand-on-hand maneuver. The leading eyelet is first introduced into the capsular bag. Then, with a hand-on-hand maneuver, the rest of the capsule tension ring is negotiated into the capsular bag. Please note that the extent of zonular dialysis is way more than what we anticipated. The trailing eyelet is introduced into the capsular bag with the help of a McPherson forceps. We can see now the capsule tension ring within the capsular bag. Note that the superior edge of the ring is visible still. This signifies the need for some more augmentation of the capsular bag, which I would provide with the help of a capsule tension segment once the nucleus disassembly and emulsification is completed. Now see what happens when we introduce viscoelastic. I'm able to visualize the nasal edge of the nucleus without seeing a corresponding part of the CTR there, which makes me think now that the trailing eyelet of the CTR has not actually entered the bag but has gone in the ciliary sulcus. Now let's see how we retrieve it and reintroduce it into the capsular bag. To start with, we need to confirm this by aiding further visualization of the capsular bag edge, which I'm able to achieve with the help of a Y-shaped hook. Now here's how we retrieve the capsule tension ring from the sulcus. With the help of a Google and hook, the capsule tension ring, which is in the sulcus, is hooked and brought towards the center. After stabilizing it, with the other hand, an intraocular forceps is then introduced into the eye and grasps the capsule tension ring. An attempt is then made to rotate the CTR to try and see if the trailing eyelet is visible. And despite the maximum rotation possible with the CTR held with the forceps, the trailing eyelet was not visible. A second intraocular forceps is now introduced into the eye, and that grasps the CTR as well. With the two intraocular forceps now working hand on hand, the CTR is carefully rotated and introduced into the capsular bag. This is what you will see in this part of the surgery. The capsule tension ring is now truly within the capsular bag. Following a limited hydrodissection, we then proceed with the phacoemulsification. Now, the technique that we are going to use here is the direct chop technique. Since this is a moderately dense cataract, in order to perform the direct chop technique, I would use the burst mode using a power of about 40%, a vacuum of 350 and a flow rate of about 28 to 30 cc per minute. Let's now watch as we proceed with the nucleus emulsification using the direct chop technique. The first few attempts at chop are successful, enabling me to break down this moderately hard cataract into smaller fragments. These nuclear fragments are now brought up into the pupillary safe zone and emulsified. Viscoelastic is intermittently introduced into the anterior chamber to aid protection of the endothelium during the emulsification of these individual fragments. Now here's where the problem starts during the nucleus emulsification. An attempt to rotate the nucleus to bring it to lie opposite the probe for further downsizing and emulsification reveals a lot of resistance to the rotation of the nucleus. I still attempt to try and break down the nucleus despite its inability to rotate. A few of the fragments are subsequently downsized and emulsified, and furthermore, I am unable to rotate the nucleus despite multiple attempts at doing so. It is at this point where I take a decision that I'm probably not going to be able to continue with the phacoemulsification, and I decide to now convert to a manual SICS. In this part of the surgery, we will see how this conversion to manual SICS takes place. We start by enhancing the visibility of the superior aspect of the sclera by taking the bridal suture. In preparation for making the SICS tunnel, we start with performing a conjunctival peritomy, clearing the episcleral surface, achieving hemostasis, and now we are ready to make the scleral tunnel. Now remember that when we do convert from a phaco to a SICS, there is an overlap between the main incision, that is the 2.8 tunnel, and the proposed site for the scleral tunnel. So after creating your initial groove, which would be only large enough to remove the fragments and allow for the introduction of the IOL, the scleral tunnel is fashioned in exactly the same manner as you would for a manual SICS surgery. I would ignore the presence of the 2.8 tunnel and create a tunnel in the desired plane, negating the presence of the existing 2.8 clear corneal tunnel which was made for phacoemulsification. Let's now watch how that is done. Note how when I get to the part where the 2.8 tunnel was taken, I maintain the plane that was created in the first half of the scleral tunnel to complete the scleral tunnel, even which underlies the clear corneal tunnel. The entry into the anterior chamber and its enlargement also takes place within the plane thus created. Having now understood how to create a scleral tunnel when you already have a 2.8 mm tunnel which was planned for the phacoemulsification, we now need to be able to prolapse the capsular bag with the retained nucleus and the retained CTR as an intracapsular procedure into the anterior chamber prior to prolapsing it out of the eye. In order to do so, I pass a Sinskey hook deep to the capsular bag, stabilize it with a view of preventing it to fall back into the vitreous, and rotate the capsular bag into the anterior chamber. A rhexis is then introduced through the main tunnel under the capsular bag, which then stabilizes it and nudges it out and brings it out along with the CTR into the anterior chamber. The next challenge is, how do we bring out a capsular bag with a CTR, the diameter of which is certainly larger than the length of the tunnel, out of the main incision? Now, in order to be able to do so, what I had to do is take a McPherson's, hold on to the CTR and just pull it out. This is followed by the removal of the nuclear fragment with the help of the vectors. I then introduce some viscoelastic into the anterior chamber to prevent those tiny fragments from falling back into the vitreous, as well as prevent the vitreous from prolapsing. I then inject 4 milligrams in 0.1 ml of non-preserved triamcinolone acetonide into the anterior chamber with the view of delineating any vitreous should it have been disturbed. I now proceed to perform a limited anterior vitrectomy. The vitreous is cleared from the wound and from the anterior chamber with the help of a 20-gauge cutter. The settings used are a cut rate of 700 cuts per minute with a vacuum of 150 millimeters of mercury. Let's now watch the anterior vitrectomy procedure. The residual epinuclear tissue, which was lying close to the cornea, is removed with the help of either the IA cut or with the cut IA as demonstrated here. Care and caution needs to be exerted to prevent the dislodgement of these small pieces of tissue into the vitreous. As a final check, I introduce some more triamcinolone into the anterior chamber just to ensure that my anterior chamber is truly free of vitreous at the end of the anterior vitrectomy procedure. Since we have decided to implant an anterior chamber lens, we introduce some intracameral pilocarpine with a view of constricting the pupil. The excessive pilocarpine is then washed out gently from the anterior chamber. Now, since an anterior chamber lens can induce a pupillary block, we now proceed to perform an iridectomy using a vitrector. Here's how it's done. At a cut rate of 60 cuts per minute and a vacuum of 150 millimeters of mercury, an iridectomy is thus created. And this is finally followed by the introduction of the anterior chamber implant under air into the anterior chamber. The IOL power needs to be worked out appropriately. Because of its anterior placement, the IOL power is roughly 2.5 diopters less than the PC IOL, which would otherwise have been implanted. Let's now watch the implantation of the anterior chamber IOL in the eye. I like to implant the lens under air, and I ensure that at all times I maintain the anterior chamber, that is, I avoid loss of the air through the main tunnel during its entry. The other advantage of using air as opposed to viscoelastic for the introduction of the lens is that I reduce another step of removing the viscoelastic from the eye when anyway I have a compromised situation of an absent posterior capsule. Following the successful implantation of the anterior chamber lens, I now proceed to perform an adequate wound closure by performing a stromal hydration of the smaller incisions, and then I take 3 interrupted tenonylon sutures in order to ensure an optimal closure of the main incision. Here's the main tunnel optimally closed with 3 tenonylon sutures. Finally, I go ahead and hydrate the incisions once more, including the clear corneal phaco tunnel, which was made in the beginning of the surgery. And finally, the conjunctival closure is achieved by the use of a bipolar cautery. And this finally brings us to the end of the surgery. I hope you found this video tutorial useful. It's extremely important for all of us as cataract surgeons to be equipped with a deep understanding of the principles and the technique of converting from phaco to a non-phaco procedure should we ever end up finding ourselves in a compromised situation. You can choose to convert to an extracapsular cataract surgery. My personal choice is to convert to a manual SICS, as I believe that it gives me a lot more control on my post-operative astigmatism. And here's how I did it. Thank you.